It is 11 o'clock at night. The house is quiet. The street is quiet. You turn off the light, and that is when it starts. A thin, high-pitched whine, like a television left on in another room, except there is no other room. It is inside your skull. It does not move when you turn over. It does not fade when you cover your ears. It gets louder in the quiet. According to the Centers for Disease Control and Prevention, tinnitus affects 14.3% of Americans over the age of 60, more than twice the rate seen in younger adults. And the most important statistic in this video is not the prevalence, it is this. The vast majority of people treated for this condition are being treated in the wrong location. Not because of negligence, because of a fundamental misclassification that has persisted in mainstream medicine for decades. Your ears, in most cases, are not the problem. And at the end of this video, I am going to reveal a published protocol from one of the world's leading scientific journals that demonstrates how the brain can be trained to generate silence. Not through medication, not through noise masking, but through a counterintuitive approach that costs nothing and requires only 15 minutes per day. My name is Dr. Chandler. I specialize in gerontology, the biology of aging and the specific ways that systems once considered irreversible can be supported, retrained, and restored. I want to begin with the research that reframes this entire problem. In 1999, neurologist Robert Levine at the Massachusetts Eye and Ear Infirmary, one of the most respected auditory research centers in the world, published landmark research in the British Medical Journal identifying a specific category of tinnitus he called somatosensory tinnitus. His finding? In a significant proportion of tinnitus patients, the sound originates not from damage to the inner ear, but from mechanical signals generated by the muscles and joints of the neck and jaw, which the auditory nerve misinterprets as sound. The ear is receiving false information from its neighbors, not from damage, from mechanical miscommunication. This research was subsequently expanded and published in Hearing Research Journal, confirming that somatosensory tinnitus represents one of the most common and most undertreated categories of the condition. Now, I promised you something at the end of this video, a protocol published in the Proceedings of the National Academy of Sciences that trains the brain to reorganize itself around silence. Not to mask the sound, you need to stop generating it. I will explain it completely. But first, you need to understand what is specifically happening in your body after 60. Here is what the research confirms about what is specifically different about tinnitus in a body over 60. First, the cochlear hair cells, the sensory cells inside the inner ear that convert sound vibrations into nerve signals, do not regenerate in adult mammals. Research published in the Proceedings of the National Academy of Sciences confirmed that cochlear hair cell regeneration capacity in humans declines to essentially zero by the mid-60s. Every hair cell lost after that point is permanently lost. This does not mean tinnitus is inevitable or irreversible. It means that the cause must be addressed at its source, because the cochlea cannot repair itself the way other tissues can. Second, cervical spine degeneration, the progressive wear on neck vertebrae and discs, accelerates significantly after 60, and the vertebral arteries, which supply blood to the auditory centers in the brainstem, run through bony channels in the cervical vertebrae. When those channels narrow with age-related changes, blood flow to the auditory system becomes compromised, and the brain amplifies its sensitivity and response. Third, melatonin production, which most people know only as a sleep hormone, declines by 70 to 80% between the ages of 20 and 70. And melatonin is simultaneously the most potent, natural antioxidant protecting cochlear tissue from oxidative damage. Its collapse after 60 leaves the cochlea progressively more vulnerable. 3 compounding factors, all specific to the aging body, none addressed by a standard ENT prescription. Before we address each one, you need to identify which category of tinnitus you are dealing with, because the approach that resolves one type will not touch another. 4 types. Listen carefully and identify yours. Type 1. Pulsatile tinnitus. The sound pulses in exact rhythm with your heartbeat, When your heart speeds up, the sound speeds up. This is turbulent blood flow through narrowed vessels near your auditory nerve. It requires vascular evaluation. Type 2. Clicking or crackling tinnitus, rapid, irregular clicks, like bubbles popping or a distant machine gun. Often occurs during swallowing or yawning. This is the stapedius or tensor tympani muscle twitching, the smallest muscles in the human body, located inside your ear, responding to magnesium deficiency or chronic stress. Type 3. Constant phantom tone, a steady, monotone, high-frequency whine or hiss that does not pulse and does not vary. This is the most common type in adults over 60. It is a signal generation error in the auditory cortex, your brain producing sound to compensate for reduced cochlear input. Type 4. Somatosensory tinnitus. The sound changes when you move your jaw, turn your neck, or press specific points on your shoulder. This means the signal is mechanical, coming from muscles and joints, not from the inner ear. Before anything else, I need to address 4 specific warning signs that require immediate specialist evaluation rather than self-care. 1. Tinnitus strictly in one ear only. Not both, not inside your head, one ear. This requires imaging of the auditory nerve. 2. Tinnitus accompanied by spinning vertigo, the room rotating, with nausea. 3. Sudden hearing loss. Normal yesterday, muffled today. You have a 72-hour window for effective treatment. Act immediately. 4. Any neurological symptom alongside the sound. Facial weakness, vision changes, slurred speech. Emergency evaluation. Now. If none of these apply, breathe out. What follows is for you. Cause 1. The somatosensory source, when your neck and jaw are making the sound. Most people believe tinnitus comes from inside the ear. Robert Levine's research at Massachusetts Eye and Ear established that in a substantial proportion of patients, the signal is generated by mechanical tension in the muscles of the neck and jaw, transmitted to the auditory nerve through shared neural pathways. The sternocleidomastoid, the thick muscle running from behind your ear to your collarbone, sits directly over the neurovascular bundle, the cluster of arteries, veins, and nerves that feed your auditory system. When this muscle is chronically shortened from forward head posture, the position most Americans hold for 8 or more hours daily, it compresses the vertebral artery below and the jugular vein above. Blood in, blood out. Both compromise simultaneously. A study published in the European Archives of Otolaryngology confirmed that somatosensory modulation of tinnitus, the ability to change tinnitus intensity through jaw and neck movement, was significantly more prevalent in adults over 60 than in younger adults, likely due to the combined effect of age-related cervical degeneration and accumulated postural habits. Now, your self-test. This will take 90 seconds and tell you more than most ENT appointments. Test 1. The neck rotation test. Sit upright. Slowly turn your head to the right as far as it will comfortably go. Place your right palm against your right cheek and gently push your head against your palm, creating resistance without actual movement. Hold for 5 seconds. Now listen to the tinnitus. Repeat to the left, then slowly tilt your head forward, bringing your chin toward your chest, stretching the back of the neck. If the ringing changed, louder, quieter, or different in tone, at any of these positions, your tinnitus has a cervical origin. The test just confirmed it by mechanically loading the muscles that are compressing your auditory blood supply. Test 2. The jaw modulation test. Open your mouth as wide as possible. Hold 5 seconds. Listen. Now clench your teeth firmly. Hold 5 seconds. Listen. Now push your lower jaw forward, chin jutting out, and hold 5 seconds. Listen. If the sound changed at any of these moments, you have somatosensory tinnitus with a jaw component. The temporomandibular joint shares a paper-thin bony wall with your middle ear. The joint head is pressing against your auditory architecture. Here is what to do. The SCM release. Using a gentle pinch grip, Capture the belly of the sternocleidomastoid muscle mid-neck between your thumb and index finger. Roll it slowly. You will feel pain. That pain is the diagnostic and the treatment simultaneously. 3 passes on each side, performed exclusively on a long, slow exhale. The exhale activates the parasympathetic nervous system and allows the muscle to release. Without the exhale, the release is temporary. For the jaw, a warm face cloth held against the temporomandibular joint for 5 minutes before sleep. Its effectiveness for reducing morning tinnitus severity is documented in the Journal of Orofacial Pain. Cause 2. The magnesium emergency. The mineral your cochlea is running out of. Inside your cochlear hair cells, there is a specific receptor type, the NMDA receptor, that governs how the cell responds to incoming sound signals. Under normal conditions, magnesium partially blocks this receptor, preventing it from becoming overactivated. When a sound stimulus is present, the block lifts, the signal passes, and the receptor closes again. When magnesium is deficient, the block is absent. The receptor remains partially open, even in silence. The hair cell fires continuously. And the auditory cortex interprets that continuous firing as a constant tone. This is the biochemistry of phantom sound. A randomized controlled trial published in the American Journal of Otolaryngology, Cevette and colleagues, confirmed that magnesium supplementation produced statistically significant reductions in tinnitus severity in patients with documented magnesium deficiency. For seniors specifically, magnesium absorption from food declines by approximately 30% after age 65 due to reduced gastric acid production. Documented in the Journal of the American Geriatric Society, simultaneously, aging kidneys excrete more magnesium. The result, most American seniors are in a state of chronic marginal magnesium depletion, with no obvious symptoms until the nervous system begins showing signs of overexcitability. Here is what to do. Not magnesium oxide, like it absorbs poorly and produces digestive discomfort. Choose magnesium glycinate, 320 to 420 milligrams for adults over 60, taken in the evening. The glycine component additionally supports GABA function in the auditory cortex, reducing cortical excitability from 2 directions simultaneously. Results in tinnitus severity typically become noticeable after 4 to 6 weeks of consistent supplementation. Not 4 days, 4 weeks of consistent daily use. Cause 3. The nocturnal cochlear crisis. What your pillow is doing to your hearing. I want to share a case from clinical practice. A 67-year-old retired nurse, I will call her Patricia, came to my practice with tinnitus she had carried for 3 years. She described it precisely, a high-pitched whine, like a television left on in an empty room. Never silent, worst in the morning. Her ENT had told her, "At your age, some hearing changes are normal. Try a white noise machine at night." A white noise machine? For a retired nurse who had spent 4 decades teaching other people how to diagnose. She sat across from me quietly devastated. I asked her one question she had never been asked in 3 years of appointments. "When did you last sleep without a pillow?" I explained the mechanism. Your vertebral arteries, the blood supply to your auditory brainstem, run through bony channels inside your cervical vertebrae. When you sleep on a high, plush pillow, your neck bends forward at 25 to 35 degrees. For 7 to 8 hours every night, those channels are kinked. Blood supply to your auditory centers is reduced for the entire night, precisely when the cochlea is supposed to be recovering from the day's acoustic load. She bought a cervical roll that evening. Within 24 hours, she sent me a message. The morning ringing, always her worst moment, was measurably quieter. Not gone, but different. For the first time in 3 years, she woke up and the sound was not the first thing she registered. Here is what to do. Replace high pillows with a cervical roll or orthopedic contour pillow that maintains neutral cervical alignment. Head in line with spine, no forward flexion. This is not optional comfort equipment for tinnitus patients over 60. It is the difference between 8 hours of cochlear recovery and 8 hours of vascular compression. And the melatonin connection, a randomized controlled trial published in the International Tinnitus Journal, Rosenberg and colleagues, confirmed that melatonin supplementation at 3 milligrams before sleep produced statistically significant reductions in tinnitus severity, particularly in patients over 60 with sleep disruption. The mechanism is dual. Melatonin restores the nocturnal antioxidant protection of cochlear tissue that declines after 60, and it improves deep sleep architecture, during which the auditory cortex performs its own maintenance and recalibration. 0.5 to 3 milligrams of melatonin 30 minutes before sleep. Not high dose. The research supports lower doses in older adults, where melatonin clearance is slower. Cause 4. The GABA deficit. When your brain loses its silence filter, your brain processes far more sound than you are ever aware of. Every heartbeat, every breath, the flow of blood through your vessels, the electrical activity of your own nervous system. None of it reaches your conscious awareness under normal conditions, because your auditory cortex maintains a powerful inhibitory filter, built primarily from neurons that use GABA, gamma-aminobutyric acid, as their neurotransmitter. GABA is the brain's primary inhibitory signal. It is what keeps internal noise below the threshold of conscious perception. Research published in PLOS One, Llano and colleagues at the University of Illinois, confirmed using advanced neuroimaging that GABA activity in the auditory cortex of tinnitus patients is measurably reduced compared to tinnitus-free controls of the same age. The auditory cortex is not generating a new sound. It is failing to suppress the sounds your body was always making. For seniors specifically, GABA synthesis declines with age, documented across multiple neuroscience publications, and is one of the reasons anxiety, sleep disruption, and sensory hypersensitivity all increase after 60. Here's what to do. The most evidence-supported GABA activating stimulus available requires no prescription and no supplement. Prolonged nasal exhales, specifically exhales lasting 6 to 8 counts, are the most direct, immediate GABA activating stimulus available. Each extended exhale fires the vagus nerve, which increases GABAergic inhibitory tone in the auditory cortex within seconds. This is the physiological reason why relaxation reduces tinnitus, and why performing exercises without extended exhales dramatically reduces their benefit. Every technique in this protocol must be performed on a slow, extended exhale. Not optional. The exhale is the mechanism. Without it, you are performing the movement without the therapy. In 2010, a research team at the University of Münster in Germany, led by neurologist Hidehiko Okamoto, published findings in the Proceedings of the National Academy of Sciences that fundamentally challenged how we think about tinnitus treatment. Their hypothesis was radical. If tinnitus is caused by overactivity in a specific frequency region of the auditory cortex, what happens if we systematically remove that exact frequency from the music the patient listens to, not to mask the tinnitus, to create an organized absence of the tinnitus frequency in the auditory input? The principle they were applying is called lateral inhibition, the auditory cortex's tendency to suppress activity in neural regions adjacent to zones of strong input. By removing the tinnitus frequency from music, the regions immediately above and below that frequency would receive strong input and would laterally inhibit the tinnitus-generating region. The auditory cortex would be trained, through neuroplasticity, to suppress the very frequency it had been overproducing. Their trial ran for 12 months. Participants listened to notched music, their preferred music with their tinnitus frequency digitally removed, for 1 to 2 hours daily. Result: statistically significant reductions in tinnitus loudness and cortical excitability at the tinnitus frequency, confirmed by both subjective reporting and EEG measurement of auditory cortex activity. The brain had reorganized itself around silence, not suppressed by medication, not masked by white noise. Neurologically retrained. This is the most empowering finding in tinnitus research of the last 2 decades, and it requires no prescription, no clinic visit, and no equipment beyond a pair of headphones and access to a free audio editing tool. Here is the protocol. Step 1. Identify the approximate frequency of your tinnitus. Online tone generators, freely available, allow you to match a test tone to the pitch of your tinnitus. Most common range in adults over 60, 4,000 to 8,000 Hz. Step 2. Use a free audio tool. Audacity is the most widely available, to apply a notch filter at that frequency to music you genuinely enjoy. The notch width in the Okamoto protocol was approximately 1 octave around the tinnitus frequency. Step 3. Listen to notched music through over-ear headphones, not earbuds which create pressure on the eardrum, for 60 to 90 minutes daily. The key is regularity over months, not intensity over days. The original trial showed measurable changes at 3 months, sustained benefit at 12 months. This is neuroplasticity applied directly to the most distressing symptom of auditory aging, by the same mechanism that allows stroke patients to recover speech and musicians to train perfect pitch. Your auditory cortex can learn silence the same way it learned to hear. I want to hear from you right now. Tell me exactly what you hear and how long it has been with you. A thin mosquito whine? A low industrial hum? A pulsing in rhythm with your heartbeat? Something that changes when you move your jaw? Leave it in the comments below with your age. I read every single one, and your description may become the subject of the next deep dive video. If someone you love is over 60 and has been told to simply learn to live with it, share this video with them today. Those 4 words do not have to be the end of the conversation. Now, if your auditory cortex is in a state of chronic overexcitation, there is one specific blood marker that predicts this, and that directly reflects the GABA deficit we discussed today. Most seniors have never had this tested. Most physicians have never ordered it. Watch this video next. I will tell you exactly what it is and what correcting it does for both your hearing and your sleep.